is multimodal imaging in posterior polar annular choroidal dystrophy. It is a rare entity characterized by late onset nyctalopia. The patients usually present with the fundus feature of peripapillary and annular chorioretinal atrophy, which extends along the temporal arcades. The fovea is usually spared till later stages. It is also characterized by normal caliber of vessel and lack of disc pallor. Hereby, we present a case series of 8 patients presenting with the characteristic fundus findings along with late onset nyctalopia. So the first case is a 54-year-old male presenting with both eyes post barrage laser with a visual acuity of 6 by 7.5. As we see in the fundus, there is a peripapillary annular chorioretinal atrophy with foveal as well as periphery sparing. Barrage laser marks are seen, and there is relative lack of disc pallor. The autofluorescence also shows corresponding hypoautofluorescence area with hyperautofluorescence at the center. ERG shows reduced scotopic and photopic responses, and HVF30-2 shows tubular fields in both the eyes. Next is a case of 61-year-old male presenting with a relatively maintained visual acuity of 6.9 in both eyes with fundus findings as shown. The OCT shows perifoveal loss of outer retinal layer with foveal sparing noted along with choroidal thinning corresponding to the area of the atrophy. Tubular fields are noted in HVF30-2 along with decreased both responses on ERG. Third case, again the patients presented with visual acuity of 1 by 60 and 624. Here in the fundus, along with the previous findings, foveal atrophy is noted along with pigmentary changes in the nasal retina. The corresponding autofluorescence is as shown. Here the patient presented with RP and photoreceptor atrophy exactly at the fovea. ERG again shows reduction in both responses. Fourth case, the patient presented with a visual acuity of 618 and 6 by 48. Fundus photo and autofluorescence are as shown. OCT shows pigment deposit with RP and photoreceptor atrophy at the fovea. Fifth case, the patient presented with a 66-year-old male. Patient had a visual acuity of 624 and 636. Fundus photo and autofluorescence are as shown. Again, foveal sparing is noted in the OCT. There is gross reduction in sensitivities on the visual fields, and ERG shows reduction in both responses. Sixth case is a 60-year-old male. This patient had a positive family history, and the visual acuity was 1 by 24 and 6 by 24. The patient, along with the previous fundus findings, also presented with a concentric perifoveal rim of atrophy. The autofluorescence image is as shown. Again, foveal sparing was noted at the in OCT, and both response reduction noted in ERG. Seventh case, the patient presented with a relatively maintained visual acuity of 6 by 12. Fundus is as shown with corresponding autofluorescence image and foveal sparing along with annular perifoveal field loss on visual fields. The last case, the patient presented with a positive family history, 6.9 maintained vision in both eyes, fundus findings as shown, foveal sparing on OCT, tubular vision along with both response reduction on ERG. So in our case series, the male to female ratio was around 5:3. The mean age of presentation was 54.5 years. Positive family history was noted in 2 cases. There was no history of consanguinity, and visual acuity ranged from 6 by 7.5 to 1 by 24. The characteristic fundus findings were noted in all cases, foveal sparing in all except 4 cases. And there was lack of significant disc pallor and vascular attenuation. So based on the above findings, investigations as well as clinical features, a few differential diagnoses was considered. We ruled out late onset retinitis pigmentosa based on the absence of characteristic findings like disc pallor, bony spicules, and arterial attenuation. Late onset retinal dystrophy patients usually present with sub-RP punctate deposits in the fundus. Pericentral pigmentary retinopathy, cone rod dystrophy, and azure usually present at an earlier age of onset. Pigmentary paravenous retinochoroidal atrophy are usually asymptomatic at presentation and do not present with and usually have a characteristic paravenous pigment distribution. Even serpiginous choroidopathy do not present with night blindness and have an earlier age of onset. These are the case reports and case series of PPACD cases presented earlier along with clinical features and multimodal imagings. So in conclusion, we are hereby describing a case series of patients with late onset nyctalopia with fundus showing chorioretinal atrophy in a typical annular fashion. Clinical features fit into the diagnosis of PPACD. Multimodal imaging aids in ruling out differential, however, genetic confirmation is desirable. Further research may be needed to better characterize the condition and its course. Thank you.
Thank you. Very nice paper. The phenotype was
Yes, sir.
extremely variable. How do you explain
sir.
that?
So we've taken a set of patients who presented with late onset nyctalopia after 45 years of age. The clinical presentation itself was nyctalopia, and the characteristic fundus findings again were the temporal arcades and peripapillary atrophy in a contiguous manner. This is what we took as a finding.
Logically, this would be because of differences in the genotype, isn't it?
Yes, sir.
So, did you do genotyping for
none of the patients were ready for a genetic confirmation. Even the previous PPACD cases that we have noted, sir, only out of the presented case reports and case series, only one have mentioned a genetic testing done for the patients. A myriad of genetic genes were tested, but none of them were noted to be positive. So PPACD does not technically have a gene corresponding to the
I guess
phenotype.
it would need to be studied, isn't it?
Yes, sir. Yes, sir. That is the one of the limitation of our study that we do not.
Maybe you should, start with that. Okay?
Yes, sir. Yes, sir.
Because the last case which you showed was almost like a sign pigmento.
Yes, sir. Again, sir, the disc pallor, lack of bony spicules, and
yeah, but as time progresses, probably it might change. As it
maybe, sir.
progresses.
Yes, sir.
Anyway, thank you.